Good evening, friends. I warmly welcome all of you for this edition of the Postgraduate PG Clinics. So we have a very eminent faculty joining us today. Professor Guru Shantapa sir is the head of the department at KIMS Hubali. Welcome, sir. We have Professor Nitin Garg. He is the head of the Department of General Surgery at PCMS, People's University Bhopal. And we have other Professor Vipul sir. He is from Palanpur, and Professor Anandara Amakrishnan sir is expected shortly. We also warmly welcome our own senior faculty, Professor Kanna sir, Professor Nishikant sir, and others. Warmly welcome all the other faculty who have joined here, as well as warm welcome to all the residents who have been presenting here. Today we have two cases, very common short cases. We've been quite some time not doing the short cases. So this week we worked two short cases. One is inguinal hernia and the other one is a cutaneous cancer. I am sure all the examiners have been with us earlier. So this will be like a teaching model. So we have 45 minutes to 1 hour for each case so that we can have an elaborate discussion on the management issues also. So I welcome Dr. Maria Syed to share her PowerPoint and start her presentation. Students, please introduce yourself, your unit chief, your head of the department, and start your presentation. Faculty, allow the students to run through the history part of it, and you can, at the end of the history, you can get back to each slides and start questioning. And I request you to give the answer if the student struggles to give the answer. So, and then they run through the clinical examination without halt. And then after the clinical discussion, kindly move on to investigations and the management part also. So good luck to both the students. Dr. Syed, Maria Syed, you can share your PPT and start your presentation.
Okay. Good evening, everyone.
You can start your presentation, Numa. You have any challenges?
No.
Raghavendra, you have to unshare your PowerPoint. You can make it full screen, Dr. Maria. Do you have any challenge in doing it?
Yes, sir.
You go to the top,
I'm
go to the
doing it, sir. Just
view command. Next to that, you can see a couple of things before is the slideshow. On the top, if you see home, insert, design, on that, after the animation, you have the slideshow mode. Are you able to see that?
Slideshow is on, sir. I want it.
It looks like it has gone small, ma.
Yes, sir. Just give me a moment. I'll share the screen again.
Okay, you just do something like this. Please unshare now. Dr. Maria, if you have any challenge, you can present as a second case.
No, sir. I've shared, sir.
We are seeing the regular mode, Kana. You have to switch on the slideshow mode. Okay, no worries. You start your presentation. We are already delayed. Professor Vipul sir, good evening, sir.
Good evening, sir.
Thank you for joining today, sir. Professor
Thank you
Dalvi
very
sir, good
much,
evening,
sir.
sir.
Good evening.
Professor Mukesh sir, good evening.
Good evening, sir.
Good evening, sir.
Sir, it is something like that only, sir. I start my
No problem, Mai. You please start your presentation. You please advance the slides in this mode only and complete your presentation. Please go ahead.
Okay. Good evening, everyone. Myself, Dr. Maria. Vijapur. I welcome you all to the session of PG Clinics this Friday. My guide is Dr. Sajid Mahmood Ahmed, sir, and presentation is guided by Dr. Nishikant Gujar, sir, Professor, Al-Amin Medical College, Vijapur. So, with the case goes as follows.
Your voice is not
A
clear.
40-year-old.
Maria,
Voice
I
is
think
coming
you have
broken.
some challenge with your internet. So the idea will be if you can rectify that, you can rectify that with a different network and comment, because we find difficult to understand what you are talking. That will make the discussion very challenging. So what you do is you can unshare now, get into a better network, and then start your presentation as a second case. All right.
Okay, sure, sir. Sure.
Okay, you please start out the network issue and then we will start the presentation as a second case. Dr. Raghavendra, can you please share your PowerPoint and start your presentation?
Yes, sir.
Can others
Good
please
evening, sir.
mute, sir? Raghavendra, we are yet to see your slides.
Good evening, sir.
Good evening, Ma. Have you started sharing, Ma?
I think the first candidate needs to unshare probably.
No, sir. Actually, there is some challenge today. I think probably the candidates network is not good enough, I guess, sir. Probably that's the reason there is a slow lag from their side also. Both the candidates have some challenge in the internet, I guess, sir. Yes, sir. Finally, I think we got it. Raghavendra, make it full screen, ma.
Yes, sir.
Dr. Raghavendra,
Yes, sir. I'm sharing, sir.
please start your presentation, ma. Why are you
Yes, sir.
waiting for?
So good evening, sir.
Yes, please. Start your presentation.
Good evening, sir. I'm Dr. Raghavendran from KUP Government Medical College, Trichy, sir. Under the guidance of our professor and HOD, Dr. Shantini ma'am, and my unit chief, Dr. Muttaraj sir, and my assistant, sir, Dr. Shivkumar sir and Santosh Kumar. Sir, I'm presenting a case of cutaneous malignancy, sir. Case of 66-year-old male hailing from Lalgudi, Trichy. He is a farmer by occupation, belonging to low socioeconomic group, according to modified Kuppaswamy scale, with the chief complaint of ulcer in the lower back for 3 years, which was insidious in onset. The patient initially developed multiple painless red small blisters in the left lower back, for which he took some topical native treatment, which remained unchanged without the history of itching or burning sensation, which later coalesced to form an ulcer, smaller in size, corresponding to the size of a coin. It remained for 2.5 years. Later, it became rapidly progressive in growth in the past 6 months to attain the present size. He had a history of serious inguinal discharge, with a history of occasional bloody discharge, and no history of pain over the ulcer in the initial period. And now the patient developed pain in the past 6 months. He had a history of prolonged sun exposure, since he is a farmer by occupation. And no history of any other ulcerations in the body. He had no history of fever or itching. No history of loss of appetite and loss of weight, and no history of any burn scar, and no history of any swellings in the groin region, and there is no history of any hyperpigmented skin lesions in the skin lesions or eye lesions. He had no history of any photosensitivity. So RCC is not a non-diabetic or a hypertensive or a COPD or with seizure disorders. He had a history of tobacco chewing for more than 40 years. He is a chronic alcoholic for more than 40 years. I had no any treatment history for previous skin diseases or history of any previous medications for fungal infections. From the history, my diagnosis corresponds to a malignant ulcer growth in the lower back regions.
Dr. Raghavendra.
Yes, sir.
Now, okay, I think it's only you have presented it like a short case only. So anything else in the history would you like to know? Certain other first question is it anything else in the history? And second is points in defense of your diagnosis, your first diagnosis. I think you only made only one diagnosis.
Sir, it is the patient is having the ulcer for the past 3 years, which has changed its pattern of growth with increase in size in the last 6 months, with the history of pain in the last 6 months, with the history of occasional bloody discharge, with the history of the sun exposure, prolonged sun exposure, and more the diagnosis corresponds to the malignancy, the squamous cell carcinoma of the skin, sir.
Raghavendran,
Yes, sir.
you said patient is not a diabetic.
Yes, sir.
Okay. If the patient says he is a diabetic and the same story, there is a discharging lesion in the back for months together or years together, but a patient is a diabetic, what will be your thinking at history level?
So it can be a carbon pain.
Very good. So don't straight away put a malignancy. If the patient is diabetic, commonest painful discharging lesion over the back is a carbuncle.
Yes, sir.
Is it not?
Yes, sir.
Okay. So your points in favor of malignancy is you say exposure to sunlight.
Yes, sir. And the
rapid
growth pattern altered in the last 6 months.
Okay. Okay. You have confirmed that he works without clothes?
Sir?
Without wearing clothes, he works in the field?
Sir, occasionally.
No. Before concluding that it is because of sun exposure, did you confirm that yes, he works under the sunlight without any clothes?
Sir, occasionally he works without shirts.
Fine, fine. Examination.
So, one more thing I asked, so any other predisposing, if you come across such patients who are having a suspicious looking lesions on history, would you keep anything in?
Sir, he had a initial
apart from sun exposure, like predisposing. Now see, cutaneous malignancy, especially SCC, is on a rise. In one other class of patients, now we see more increasingly. patients who are on immunosuppressive therapies. Now, a lot of transplants being done, so the incidence is rising. So that history we should keep in mind, because see, all the patients will be of different type. Not all times you will going to treat only the farmers who are being exposed to sun. So that is a very important history you should keep in mind, the drug history.
Raghavendran, is there
Yes, sir.
any difference between sun exposure in a light skin people and dark skin people?
Sir, the sun exposure in the dark in a white people, it is more prone for malignant melanoma, sir.
Only malignant melanoma or all malignancies?
Any pre-malignant condition, actin keratosis.
Why you are keeping a possibility of malignancy here? What
So
is
the
the reason for that?
patient had a initial history of a pre-malignant history of painless red small blisters in the site of ulcer, which in the site of the ulcer, sir, initially developed as a painless red small blisters, which coalesced to form the ulcer with no history of fever or with no history of any pain or any burning sensation.
Can't it because of chronic inflammation?
Yes.
Okay, patient having the tuberculosis. Can you get the tuberculosis in the lower back there because of any reason?
Yes, sir.
Did you ask about the history of tuberculosis in this patient?
So no, a patient is not no history of tuberculosis, sir.
Did you ask any history of trauma here?
No history of trauma, sir.
Do you think tuberculosis can be a differential in this patient based on the history?
Sir, the patient is not having any loss of appetite or loss of weight or no any low grade fever, history of no low grade fever.
If there is skin tuberculosis is there, what is that called as? What is the name of the skin tuberculosis?
Lupus vulgaris.
That's called a lupus vulgaris. Right. Okay. So I think probably only from the history, you just cannot say it is the malignancy. Any chronic inflammation, like even the patient has a leprosy, they can present like ulcer like that. Long duration ulcer may be there, tuberculosis may be there, actinomycosis may be there. So there are various infections, chronic infections, which can present like that. Okay. Yeah, go on the examination now.
So general examination. The patient is conscious oriented. There is no not dyspneic or not tachypneic. And
Anything positive? Anything positive here?
sir, no, sir.
Local examination.
So local examination, a single 12 cross 10 centimeter, 12 centimeter vertically and 10 centimeter horizontally, roughly ovoid ulceroproliferative growth in the left lumbar region, extending 8 centimeter superior medial to the posterior superior iliac spine and 3 centimeter lateral to the midline, corresponding to L2 to L5 vertebra with averted edges and the floor covered with a proliferative growth with slough with serous angulous discharge present. The surrounding shows mild hyperpigmentation and edema. On palpation, there is no localized warmth and no the ulcer is not tender. The single 12 centimeter and 12 cross 10 centimeter roughly ovoid ulcerative growth in the left lumbar region. The inspected findings are confirmed with the averted edges and the floor is covered by the proliferative growth with slough. No bleeding on touching. With the induration of the base is present. And the ulcer is mobile in both vertical and horizontal plane with no clinically palpable lymph nodes. And the examination of the other system, other systems are normal and no abnormalities detected, and spine and cranium are normal with sensations intact in the lower back with no paraplegia or paralysis of the lower limb. And my clinical diagnosis is the malignant ulcer.
Raghavendra, hold on. Put the examination slides.
Yes, sir.
You would like to put this as a lumbar region lesion? Anatomically, if somebody says lumbar region, what exactly it means if you are presenting something? Is it in the abdomen or is it over the back? We take this wording as
It's a
lumbar
left,
region.
back only, sir. Left back only, sir.
Back, lumbar region, if you talk, it is a back. That's what it means. How do you put this? Where is the site you will put? If you say lumbar, I may understand that you are talking about abdominal quadrants in the lumbar region. That's what my version would be.
Yes, sir.
The same area on the back, we call that as a renal angle. Okay. So
Yes,
what
sir.
is this? You cannot, Kanna sir, we cannot accept this as a lesion at the lumbar region.
But only paravertebral, he can say.
Exactly. Exactly. Paravertebral or maybe whatever the few centimeters short of the midline on the left side.
Paraspinal,
Paraspinal.
yeah.
Correct. Paraspinal area. So don't take lumbar because message conveyed will be something different.
Yes, sir.
Okay.
Did you
Okay.
examine the spine of this patient? Have you examined the spine of this patient?
Sir.
Did you examine
Spine
the
examination.
spine?
Yes, sir. The spine and cranium normal, sir.
No, spine. Lumbar spine.
Yes, sir. No, there is no lumbar lordosis or any kyphosis or scoliosis, sir.
So if I say it's a tuberculosis is there, then what you will get in the spine?
If there is any deeper, if the ulcer involves a deeper structure, it may be a tuberculous pot spine, sir.
So in the pot spine, what type of the deformity is there? In pot spine, what type of the deformity you get? Do you get kyphosis, lordosis, or scoliosis? What is gibbous?
Kyphosis.
Gibbous. Okay, gibbous is a localized kyphosis. And that is the type of the deformity you get in the case of the tuberculosis.
Yes, sir.
You find that there is a localized kyphosis is there at the level of usually the L12 S1 area. Okay. Or it may be at the thoracolumbar area. You get a gibbous there. That's a localized kyphosis is there. And
Yes, sir.
more commonly in the thoracolumbar area. Okay. So if you think it is the skin malignancy, what type of the skin malignancy you are thinking?
So it's a ulceroproliferative growth, sir.
That is
Probably-
the type
What are
of
the common skin malignancies?
Sir,
What are the common skin malignancies?
sir, I'm not able to get you, sir.
What are the common skin malignancies?
So most common basal cell carcinoma, sir.
Okay. Then
Malignant melanoma, sir.
then
any
squamous-
sarcomatous malignancy
squamous
which
cell
are
carcinoma, hai na? Okay, so basal cell carcinoma, squamous cell carcinoma, and the melanomas.
Melanomas.
So these are three common skin malignancies. And then there can be other tumors also. Adnexal tumors may be there, various adnexal tumors which may be presenting. There may be the sarcomatous tumor may be there. So looking at this, what do you think between the melanoma, squamous cell carcinoma, and a basal cell carcinoma? What is the clinical?
Raghavendran, what is your likely possibility out of those three? Sir is asking, what is the likely possibility in this case?
Sir, mostly likely my diagnosis pertains to squamous cell carcinoma of the lower back, sir.
Why do you say that?
Sir,
Squamous cell carcinoma.
sir, there's a ulcer-proliferative growth, sir,
Yes.
with everted margins,
Good.
with no pigmentation, sir.
Okay.
Raghavendra, what is the clinical examination finding for a cutaneous malignancy, or in this case, other than what you have described, what is a one more clinical examination finding which will tell us that, yes, probably it is a malignancy, which you have mentioned in your presentation?
Anything on palpation specifically?
The induration, base is induration.
Exactly. Indurated base. Indurated. You have mentioned in the presentation there are no lymph nodes. Which lymph node did you examine in this case?
Sir, superficial inguinal lymph nodes.
Okay, can you justify examination of inguinal nodes in this case? You understood?
Sir, I'm going to get you, sir.
Means what's the
How do you
sir is asking
justify?
what's the drainage?
Sir, if we ask, they will answer that. How do you justify examining inguinal nodes or groin nodes in this case? That area, where does it drain? Lymphatic wise, where does it drain?
You should pick up the hint. Huh? Take it me as an internal examiner as well as an external examiner.
Where does it drain, that area?
External details.
External inguinal. Which one? Where does it drain? Where does it drain? Inguinal area. Why hesitancy? Inguinal area. Both below and above the umbilicus on either side, anterior and posterior, they have a same. Above the umbilicus, axilla, both on the back. Lower down to the corresponding groin area. Okay, so you need to examine the groin nodes. Okay, fine. What is the commonest protruding lesion over the back if you are thinking in terms of a malignancy? Is it squamous cell carcinoma or something else? Exactly like this. Verrucous. Over the trunk,
So,
More so
trunk,
on the
the
back.
most common malignancy is malignant melanoma, sir.
No. Sir was asking Kanna sir, he mentioned some malignancies. What are the other adnexal lesions you can expect over the trunk?
Have you heard
Which
of
can protrude.
sarcomatous cutaneous malignancies?
Which can protrude from the surface of the skin, which can protrude like this, and the terminology comes out of that.
And see, nodes not palpable, that may be one of the explanation for that. With such a big lesion, have you heard of the term dermatofibrosarcoma protuberans?
Yes.
You heard or not?
Yes, sir.
That is a commonest cutaneous lesion over the trunk, more so on the back, and that to lower back.
Yes.
Dermatofibrosarcoma protuberans. It is self-explanatory tumor. It is arising from the skin. Fibrosarcoma, sarcos. That's what Nitin sir was asking. Sarcomatous element. Because it protrudes out of the surface, it is called protuberance. And there is a commonest tumor on the back. Okay. Nodes may not be inward. Nodes may not be inward over the back. Okay. How do you proceed now?
So the investigations, I do blood investigations.
1 second. If you have been asked to one of the systemic system in cases like this, which is the system you will examine and for what? In the general physical examination. If you have been asked to choose only one system, which one you will choose and for what?
So examination of the spine and cranial, spinous Vertebral column, sir.
Does these tumors spread to vertebral column?
I think sir is pointing toward whether you will go for lymphatic, hematogenous, which system we will go.
Exactly. In the systemic examination, I said, no?
Respiratory system, sir.
Okay, why? For what? What is that you will examine in the respiratory system?
For the deposition of the secondaries
So where?
in the cannonball, in the lungs.
That clinically you cannot examine, no? Clinically. So you will examine for decreased air entry or evidence of pleural effusion.
Effusion.
Pleural effusion and decreased air entry. And invariably these sarcomatous lesions will have a parenchymal deposits rather than surface deposits, which you see in CA breast. So if a tumor has got predilection for surface deposits, you will have a pleural effusion. If a tumor has got a predilection for parenchymal deposits in the lung, you will have bilateral crepitations or generalized findings. Okay. So respiratory system is the one which you need to answer for this. Okay. Continue. How do you evaluate now this case?
Proceed for the tissue diagnosis, sir.
Be specific and be fast. Yeah.
With edge-wedge biopsy, I'll do a biopsy, sir, for this patient.
Okay.
And proceed for the metastatic workout also. Metastatic workup, sir. Do a chest X-ray, CT, and CT abdomen.
Why abdomen? CT abdomen? Okay. You should, Raghavendran, you should use logic and you should use your maybe frontal lobe more whenever you have something like this. Edge wedge we accept for everything. Here it is a protruding lesion like this.
Yes, sir.
I think probably you are able to pass your fingers underneath the borders of the lesion. Am I right?
Yes, sir.
Okay. In edge wedge, what is the element you take along with the tumor?
The normal tissue, the normal tissue.
Is it possible in this case because it is coming like a cauliflower like?
Yes, sir.
So is it possible to take a normal tissue in this case?
No, sir.
So is that the right word to be used for this case? Because you cannot have a normal. In the wedge, you have to have a normal tissue there. That is why it becomes a wedge. Is it not?
Yes, sir.
So here it is only the tumor you can, because it is coming out like this, like a flower.
Shape.
No. For taking biopsy, I'm talking about. Taking biopsy. Fine.
Shape biopsy.
Shave biopsy. No, you cannot shave it. It is a big lesion. It's an edge biopsy.
Edge biopsy.
Or a punch biopsy, because it is everything is protruding. You can take a punch of tissue.
Yes, sir.
Either an edge biopsy or a punch biopsy. Either of the one. Okay?
Yes, sir.
Fine. And I expected personally, whenever things are asked, how do you evaluate in a suspected case of malignancy, you should go in 3 formats. One is for the confirmation, that is local. Second is for the regional evidence. Is there any disease in the regional area? Third, is there any disease in distant area? That is a metastatic workup. Regional you never mentioned. Okay. What is regional here? Groin area.
Right.
So what is a simple investigation? Even though clinically they are not felt, anything can be done.
USG.
Are they, first USG, then guidance. You have to look for the nodes first. If there are, then FNEC. Okay. So in the same order, then there are few investigation for anesthesia point of view, you have to evaluate. You got the point?
Else, can you ask your pathologist to do if suppose pathologist is unable to give a clear diagnosis?
Sir.
Anything else apart from histopathology, you can ask your pathologist to do if you have a feedback that diagnosis is probably not clear. Even after your biopsy, say it may turn out to be an undifferentiated malignancy.
I can proceed with the most micrographic.
See, histopathology, the routine thing we do. Now, pathologist unable to give you a diagnosis, say it is an undifferentiated malignancy. Now, see, treatment protocols are changing. Now we are going more towards some therapies even before surgery. So it may help you decide that.
Whether you will
Anything else you can ask from the pathologist.
whether you will prefer
If
to,
pathologist is unable to give the diagnosis on histopathological examination.
whether you will prefer repeat biopsy or you will prefer any other further sophisticated, whether you will prefer repeat biopsy or you will prefer to go for another sophisticated histopathological diagnostic technique. Any advanced technique you will go for.
Sir, I
If
can go
a
for a
pathologist is saying,
most micrographic.
no, that is surgery type. That is
See,
surgery.
if your pathologist say inconclusive, then probably repeat biopsy. But malignancy, there is no doubt. Type of malignancy, you can very well go for immunohistochemistry. That's the simplest answer.
That
to
is
start.
further sophisticated technique.
So it may come in help in typing the cutaneous malignancies whenever there is a doubt, or even to decide on some, if you're not planning for upfront surgery.
In any undifferentiated malignancy, pathologist is giving undifferentiated malignancy. Even in any biopsy, you can go for immunohistochemistry for further type. That will help.
Why CT abdomen, Raghavendran?
Sir, to look for the deeper extension of the.
Oh, in the lesion you want to check.
Deeper extension of the.
Okay, then your idea, your terminology should not be CT abdomen. CT of the local area. Okay, you want to know the extent of the tumor. That's what you meant.
Yes, sir.
Okay, fine.
Now, which is better? CT, I'm not convinced with CT.
Exactly.
If your idea is local invasion, you said the lesion is already mobile. So probably it has not gone deep enough. Now, if you want to look into the muscles or the fascia, which is better than CT?
MRI, sir.
Yes. So soft tissue invasion, it is always better to go for MRI.
Yeah, okay. Continue. Continue, Raghavendran.
Yes. And the biopsy was taken, and the biopsy came as a well differentiated invasive squamous cell carcinoma of grade 1, sir.
Okay, how did you conclude that it is a well differentiated?
So the cells are arranged in sheets of lobules with the with the hyperchromatic nuclei, with the epithelial dysplasia, with the central keratin pearls.
Anything you know about the pearls and the differentiation of squamous cell cancers?
So they are mitotic, it increased mitotic activities.
No. Keratin pearls and differentiation of squamous cell carcinoma. Anything you know about this? Okay, keratin pearls, are they normal or abnormal? Are they from the cancerous cells or are they from the normal cells?
They're from the cancerous cells.
Okay, I thought you would have prepared for the case, Raghavendran. Yeah, in a big platform.
Raghavendra.
Sir.
What are differentiating feature between squamous cell carcinoma that from basal cell carcinoma?
In the basal cell carcinoma, there is a palisaded arrangement of the cancerous cells. Sir.
And more specific? Keratin pulse formation is seen
in basal cell also, it is also seen. Sir.
What is the differentiating point between these two?
Here it is extracellular.
Hmm? First point is the basal cell carcinoma found in within deep layer of the skin. Common cell carcinoma found near the orifices and the oral cavity. Other differentiating point. Keratin pulse are commonly seen as common cell carcinoma rather than basal cell carcinoma. One more differentiating features. Why it is called as rodent ulcer? Basal cell carcinoma is called as rodent ulcer. Why it is called as rodent ulcer?
So local invasion is
It is locally invasive. It is invasive cellular disease. That's why it is called as a locally malignant. Okay, proceed.
How will you classify well differentiated, moderately differentiated, and poorly differentiated malignancy?
Sir, from the difference, the cell of origin can be identified, very well identified in a well-differentiated carcinoma cell.
Depending on the percentage of differentiated cell on the histopathology, how will
You have to unmute the audio, people.
Yeah.
Yeah.
Depending on the percentage of differentiated cell on the histopathology, how will you classify well differentiated, moderately differentiated, and undifferentiated malignancy?
Probably Raghavendran, that's what I was asking pertaining to the percentage of pulse. Okay, yes. So you have to calculate the keratin pulse percentage along with the cell appearance.
Yes.
Okay, and keratin pulse are not from the cancerous cell. It is from the normal cells.
Yes.
So higher the number of keratin pulse formation, better the malignancy. That is a well differentiated is the malignancy. What Dr. Vipul is asking, so you have to combine the percentage of pulse, keratin pulse seen per high power field plus the cellular atypia, combine these two, then tumors are graded in squamous cell. That can be done from the biopsy specimen so that you can plan your treatment, or it can be done from the histopathology after a surgical treatment. Okay, I thought you will be knowing this, Raghavendran, if you are presenting a case in a big platform. Okay. Next, this is the biopsy report.
Yes, sir.
Fine. Next, what will you do finally? Now, finally, what is the love? It is a local tumor without involving muscular layer. MRI was done. It was not done. Only CT was done.
CT was.
Okay. And a biopsy report is well differentiated squamous cell carcinoma,
Yes.
measuring 12 by 10 centimeter. What will be your plan of treatment?
I go with the wide margin excision. With the reconstruction of the defector cell.
Okay. How much wide and how much depth you will excise? It has to be three-dimensional excision, no?
Yes, it's a three-dimensional excision, sir.
Exactly. So how much wide and how much depth?
Sir,
What was earlier?
marginal
What was
clearance of
earlier pertaining to the wideness? What was earlier and what is now? Fine. How much wide you will excise? 2 centimeter, 5 centimeters, 1 centimeter?
2 centimeter clearance.
Huh? You said 2?
Yes, sir.
Okay. Okay. What is mentioned in the literature? Earlier it was 2 centimeters. Okay. Because you have a
Yes,
good
sir.
modalities now as an adjuvant treatment, and your biopsy report is well differentiated. Okay. It's a well differentiated cancer. 0.5 to 1 centimeter is enough. 0.5 to 1 centimeter. More so if the lesions are in non-sacrificable areas, like in the face. Okay. What is the depth of invasion? How will you decide? How much depth, depending on what you will decide?
Depending upon the marginal clearance.
No, depth of excision, how will you decide? On what grounds you will decide how much depth to be excised? On MRI findings, what is the anatomical layers which are involved? Okay, depending on that, you will. What is Mohs surgery? Will it come into action now? If
So
your
it is a
plan is
state-
to do a depth excision. Yeah, tell Mohs.
It's a staged excision procedure, sir, to attain the optimal margin with the maximal conservation of the tissue. So it is done along with the surgeon and pathologist go hand by hand with the excision, with the subsequent mapping and removing the margin so that till the negative margin is achieved, the excision is proceeded, sir. And it has a greatest advantage of low recurrence rate because of the optimal margin achievement and better cosmesis because of maximal conservation of the tissue, sir.
Just one logical question. You have excised in the right hand, tumor is there. Left hand is the patient side. You want to check the presence of tumor with this procedure, Mohs chemosurgery. Which side you will stain for the tumor?
Sir, I'm not able to get you, sir.
You didn't hear? My right hand contains the tumor, excised tumor. Left hand is the patient side. Your
Yes, sir.
plan is to do this Mohs chemosurgery. You have been asked to take the staining. Which side you will be doing the staining?
The side which is facing your hands.
Not no, patient side and a specimen side. I wanted to patient side or a specimen side. It is always the patient side. If that
Yes.
comes positive, then again you need to excise one more layer. It is a patient side which needs to be done and rule out that there is no tumor seen on that staining.
Yes, sir.
Till then you should go on doing it. You got the point?
Yes, sir.
Yeah, fine. How do you do the reconstruction? I feel it is a paravertebral muscles are not involved. Okay, depth wise, because you said it is mobile. So you have excised everything. How will you cover the defect?
So I can cover with the SSG, sir.
Okay, split thickness graft.
Yes, sir.
What is the idea of doing a flap reconstruction? With what intention we need to plan the flap reconstruction in such scenarios? Keeping something oncological treatment in mind.
So radiotherapy.
So what is if your plan is to do adjuvant radiotherapy to such tumors, bigger tumors, what should be the way of reconstruction?
So that margin should be negative, sir.
No. If your plan is to give adjuvant radiotherapy, what is the type of reconstruction you will plan?
Will you
Does a
prefer
grafted
SPG or
does a grafted skin
Will you
tolerate
take that?
radiotherapy?
No, sir.
Then if grafted skin cannot tolerate radiotherapy, what should be the way of reconstruction? Common, no? If split thickness cannot tolerate, what is that you will be putting there?
Then allow
What
the
you
tissue
need
to
to
granulate.
You allow the tissue to granulate. It's a huge area. Defect will be very big, no? Defect will be very big defect. And adjuvant, you cannot wait adjuvant chemo radiation till that wound heals. You cannot wait. That will take months together. By the time tumor may recur.
Yes, sir.
So how do you cover that?
mobilization.
Primary will be difficult. Okay, anyway, we expected flap reconstruction, various flaps. If your plan is to do adjuvant radiation to any skin tumors with a bigger defect, the reconstruction has to be a flap reconstruction. Depending on the site, you need to plan the flaps.
Yes, sir.
So that you can submit the patient for adjuvant radiation with the flap will tolerate better than the grafted skin. This is the answer we want.
is most
Okay.
surgery possible in every setup? Is Mohs micrographic surgery possible in every setup, or is there any prerequisite?
No, sir, it's very not suitable for all setups, sir.
What is the prerequisite for that surgery?
Sir,
What is the prerequisite for that surgery? What is the most important requirement for Mohs micrographic surgery?
sir, we need a no, sir.
Frozen section facilities must be available.
Must be, yes.
If frozen section facility is not available, then you can't go for that.
Yes, sir.
Kanagavel, sir?
Raghavan, what is the difference between excision in a case of basal cell carcinoma, squamous cell carcinoma, and a melanoma? What is the difference between these three? Wide excision you carry out for these three tumors?
Sir, for a malignant melanoma, based on the thickness of the lesion, if it is 0.7 to 0.75 to 1 millimeter, we can excise 0.5 to 1 centimeter margin, sir. And for 2 to 4, we can millimeter for we can access 1 to 2 centimeter margins here, and for more than 4 we can
1 to 4?
2
Like
centimeters.
if your case is a case of a malignant melanoma, I say, what type of the malignant melanoma it will be?
Sir,
If I say your case is a case of a malignant melanoma, so what type of the malignant melanoma it will be?
amelanotic melanomas.
Amniotic, what type? What are the types of the melanomas?
Lentigus,
Yes,
the nodular malignant melanoma.
it will be a nodular variety. You know?
Yes,
It will be a nodular variety. What is the wide excision in a case of basal cell carcinoma?
sir, for a 4 mm, it is for the lesion around 4 mm, we can give a clearance of 1 centimeter margin, sir.
Okay, so just to remember, basal cell carcinoma 5 millimeters, squamous cell carcinoma 1 centimeter, and majority of the melanomas are 2 centimeters. Okay, so just to remember this.
Yes, sir.
Now, what are the sarcomas which can metastasize to the lymph nodes? No, normally they do not metastasize, but few sarcomas can metastasize to the lymph nodes. Can you tell that? Okay, remember them by the mnemonic RACES, RACES, rhabdomyosarcoma, angiosarcoma, clear cell carcinoma, epithelioid sarcomas, and synovial.
Yes.
Okay, so these are 5 RACES by which you can remember that these are the sarcomas. Normally, the sarcomas they do not metastasize to the lymph nodes, but they can metastasize to the lymph nodes. Now, what is the name of the split skin graft? What you use? What is the name of that? Split skin graft. No, you say na split thickness skin graft you are going to use. What is the name of that? By what instrument you are taking that graft?
Humpis.
Eh? Humbees.
Humpis types.
Okay. That is called a Thier's graft. Okay, Thiers graft. And with the full thickness is there, what is it is called as? It is a wolf graft. Okay, wolf graft. Now, how does a split thickness graft survives? When you apply that, how does it survive? What happens in the first 48 hours and then later
Neovascularization.
on? You must go and read about that how does this split thickness skin graft survives, you know. There is no vascularity coming, but still it survives, you know.
Simple difference.
There are different phases for that. How does it survive?
Yes.
Okay. I think, Dr. Kanagal, we can stop here.
Sir, Kanagavel, sir.
Yes, sir.
Sir, shall we take
Yes,
the
sir. I
second
think we
case?
can move. We can allow the candidate to clarify if he has any doubts. Sir, Raghavendra, do you have any doubts to get clarified?
So, no, sir.
Thank you, Dr. Raghavendra. With the
Thank you,
permission
sir.
of the faculty, we move on to the next case now. Raghavendra, please unshare your PowerPoint.
Yes, sir. Thank you, sir. Thank you so much, sir.
Dr.
Thank you, sir.
Maria Syed, are you with us?
Yes, sir.
Okay. I hope your internet issues are sorted out now.
Yes, sir.
I
Sorted
think you
out.
moved to a better place now. Okay,
Yeah,
please
yeah.
start your PowerPoint and start your presentation.
Okay, sir.
Nitin sir, I think you wanted to leave for an emergency. Am I right, sir? I think sir has left already. Okay, make it full screen, ma.
Yes, sir.
Go to the slideshow mode. Yes.
Is it coming, sir?
No, Kana, you have to go to presentation view on the left side. You see the icon? Yes, very good. Good luck to you.
Thank you, sir.
Right.
Good evening, everyone. I'll be presenting a case of groin swelling. Myself, Dr. Maria, third year surgery resident from Alamin Medical College, Bijapur. I'm guided by Dr. Nishikant Gujar sir, Professor, Alamin Medical College, Bijapur. My guide is Dr. Sajid Mudhol Ahmed sir. So I'm starting the presentation with the particulars of the patient. A 40-year-old male, tractor driver by occupation, hailing from Bijapur, comes with chief complaints of swelling in the left groin region since 1 year, pain in the swellings 1 week. Patient was apparently history of present illness. Patient was apparently all right 1 year back. Then he noticed a swelling in the right groin region, which was initially of small size, but gradually has progressed to the present size and extended into the scrotum over the last 1 year. Swelling appears on standing, increases on straining, cuffing. Swelling does not completely reduce by lying down, but patient has to reduce it manually. Patient developed pain since 1 week, pain of dragging type, which was of dragging type, and increases on straining and walking and relieves on lying down. No history of distension of abdomen, abdominal pain, and absolute constipation. No history of similar swelling in the opposite groin or anywhere else over the abdomen. No history of burning micturition, intermittent stream of urine, increased night frequency, or urgency. No history of chronic cough, breathlessness. No history of constipation or straining at stools. No history of any surgery in the past. No history of trauma. No history of fever with chills. Alcohol consumption since 6 years and tobacco smoking for 6 years. In past history, no history of diabetes mellitus, hypertension, or tuberculosis. Personal history, diet is mixed, appetite good, sleep adequate, bowel and bladder habits regular. Summarize, a 40-year-old male patient, driver by occupation, presented with chief complaints of swelling in the right groin, which appears on standing and increases on coughing and straining and partially reduces on lying down. General physical examination.
Done with the history?
Yes,
Doctor,
sir.
you done with the history, no?
Yes, sir.
Anything can you think of at history level? It's all right. Put that summary slide.
Yes, sir. Sir, in the history-wise, the patient is telling that he is having a.
It's all right. Don't repeat. What do you think? That's all. What do you think? You mentioned.
Sir, I think that it is. It could be hernia, sir.
Could be. Okay. You want to give a differential diagnosis? If that is a thinking.
No, sir.
Hmm?
Sir, it is.
Can it be a lymph node mass? Can it be a lymph node mass at history level?
No, sir.
Why? Why not? I say it is a lymph node.
Yes, sir.
What is that from the history which will make lymph node mass unlikely?
Sir, cough impulse is present, sir.
Exactly, and it is partially reducible.
Partially reducible, yes.
Which may not happen with lymph node. And staying for how many years? 2 years.
2 years, yes.
Okay,
sir.
fine. It is for the sake of asking, we're asking. That's all. Okay. If you think at history level it is a hernia, do you think it is a uncomplicated or a complicated hernia?
Sir, it is an uncomplicated hernia, sir.
Why do you think so?
So because patient has not given any other any history of strangulation, sir, like vomiting, distension
So
of
according
abdomen.
to you, only strangulation is the complication?
No, sir.
Then?
Obstruction.
Okay.
Irreducibility.
So is this completely reducible on lying down?
Yes, sir. Completely reducible.
No, you are given the history here. Partially reduces on lying down. It is seen for all of us.
Sir, by its own, sir. But patient has to reduce it completely.
History wise, when you think it is hernia, keep it in mind before you start examining. Likely that probably it is a complicated or uncomplicated hernia. Okay. Examination. Anything in the general physical examination you have found? Next
no,
slide.
sir.
Next slide.
Guru Santapa, can I come in? Dr. Dalvi here.
Please, sir. Yeah, please, sir, please.
Maria, can you just explain in your history why did you specifically ask for fever with chills?
Sir, I wanted to.
Sir, good evening, sir. Before she answers. Good evening, sir.
Yeah, Maria, go ahead.
Sir, I wanted to rule out whether if there is any epididymitis or funiculitis or any
Which
infected
swelling in the
etiology.
inguinal region, inflammatory, actually going down into the scrotum as the history told to us, have fever with chills.
Sir, inguinal lymphadenitis, sir.
Again, the same question was asked by Dr. Guru Shantappa. Why not an inguinal swelling? You answered it will go into the it will not go into the scrotum. So be very careful when you are actually presenting a case. Okay. Otherwise, you're doing well. Go ahead.
Okay, sir.
Maria, do you know what are the various swellings which has got the cough impulse?
Sir, hernia, meningocele, sir.
Yes.
And Safina varix, sir.
Okay. Anything in the neck? Anything in the chest?
Laryngocele, sir.
Okay. Chest.
No,
Some empyema.
empyema. Okay,
Which,
sir.
which empyema is that?
Yes.
Empyema necessitans.
Empyema necessitans. Okay, sir.
Now, what are the various types of cough impulse?
Expansile and transmitted.
So, in the groin area, which swelling will be expansile and which swelling will be transmitted? In which?
Sir, in groin region, expansile will be hernia, sir.
Okay.
And Safina varix.
More than Safina varix is a little down, hai na? That's
Yes,
in the
sir.
femoral region.
In the femoral area, yes, sir.
In the groin area, in the inguinoscrotal area, which swelling will be there?
Hydrocele will not have this thing.
Varicocele.
Varicocele, yes, sir.
Yeah, varicocele will be having the transmitted type of the cough impulse. Now, what
Yes.
is the difference between a reducibility and a compressibility?
Sir, in reducibility, the opposite forces are required to bring back the swelling, sir.
Okay.
Whereas in compressibility, the swelling will gain its original size on its own, sir, after compression.
Good.
Yes, sir.
Go ahead with the examination.
Examined in a well-lit room after obtaining consent from the patient and in adequate exposure. Examination done in standing and supine position.
Anything in general physical examination? Anything found positive?
No, sir, nothing positive.
But if you are being asked to do something in the general physical examination, in this particular case, what is that you will examine? Mentioning all this, okay, fine, but pertaining to this case.
Sir, nodes, cervical nodes, I'll
Why
examine.
suddenly cervical nodes for groin hernia?
Sir, pulmonary tuberculosis. I can just.
But he doesn't have symptoms, no? This case,
No,
not in general, I'm asking, this case.
Inguinal lymph nodes, sir.
Okay, it's all right. We expected that we find out whether he's a hypertensive. Yeah, blood pressure is a must. You need to check the blood pressure.
Okay, sir.
You need to check the blood pressure because you are going to operate on him. Okay, if he's hypertensive, you need to have a control of hypertension.
He's
Okay?
normotensive, sir. Blood pressure is.
That's what you need to answer. Like,
Okay, sir.
you cannot go on writing everything. In this particular case, what exactly you need to check in general physical examination.
Okay.
Like we asked, no, if it is a patient of jaundice, in general physical examination, what is the important point you need to examine? Okay, fetal edema you need to mention because albumin is a must. You should know.
Okay.
Yeah, like that. Okay, local examination.
Local examination, both inguinoscrotal region, inspection done in standing position, a solitary swelling situated in the right inguinoscrotal region. Swelling is extending from 6 cm below the anterior superior iliac spine into the scrotum, reaching its base. It is a pyriform swelling of approximately 10 into 5 into 3 cm in size, pushing the penis to the opposite side. Skin over the swelling is normal, no redness, edema, dilated veins, scar, or pigmentation. Expansal cough impulse present, no visible peristalsis over the swelling. Scrotum appears normal. This is the figure, sir. This is the video of expansal cough, sir. Palpation. No local rise of temperature. The swelling is non-tender. The shape is pyriform shape of 10 into 5 into 3 cm, extending 6 cm below the ASIS into the scrotum. Margins are well defined. Consistency is soft and elastic. Relation of swelling to the pubic tubercle, it is medial to the pubic tubercle. Reducibility is, it is completely reducible. First part reduced with difficulty, whereas second part reduced with ease. Getting above the swelling was not possible. Testes were felt separately from the swelling. Siemens test, impulse felt on index finger. Deep ring occlusion test, swelling did not appear. Both the testes were palpable. Palpable expansile impulse on coughing over the external ring. On percussion, resonant note was present. On auscultation, bowel sounds were heard. Left inguinal region, no swelling in the opposite inguinal region. No
Can you put the previous slides? Can you put the previous slides?
Yes, sir.
Previous. No, next slide. Next slide. No, don't do it fast. No, don't do it. Yeah. Okay. So it's completely reducible.
Yes, sir. Completely reducible.
How did you do that?
Sir, by taxes, sir.
How did you do? Describe. How did you do?
Sir,
Describe.
we asked the patient to lie down, sir, and gently push the flex the knees, sir, hip joint and knee, and slightly adduct the limb, and then slowly push the contents into the abdomen, sir. Press the
With what hand did you push?
Sir, with the right hand, sir.
What is that you did with the left hand?
Left hand, I was securing the ring, sir. Neck, sir.
Okay. Anyway, all those actions of what you people like do it, no, all to relax abdominal wall may not be required. What we expect is a reducing hand and a guiding hand. Reducing with the right hand and guiding with the left hand. Very simple. Okay. And that ring occlusion test should be mentioned only when the swelling is reducible. So in your case, it was reducible completely.
Yes.
Okay. Maria, anyway, I don't know about the other examiners. You have read the slides well. You have not presented. You have read the slides. It's a PG clinics. We expect you people to present the case. It is a simple case of groin hernia. And next slide. And your written reducibility margin. Can you define like a margin for the inguinal hernia? It is not a surface swelling. It is not a surface swelling. So you should. And next slide. Next slide.
Guru Shantapa, can I come in here?
Please, please, sir.
Go back to the previous slide.
Yes, sir.
You say that completely reducible.
Yes, sir.
After reducing it completely, how is
Yes.
it possible for you to not get above the swelling?
Sir,
What
I-
is getting above the swelling?
sir, we have to palpate with our thumb and index finger above the swelling, sir, to palpate the cord structures.
Above the swelling? What do you palpate when you try to actually, after reduction, palpate?
Cord structures, sir.
Correct. So now which of your two is correct? Reducibility and getting above the swelling.
Sir, I did not reduce the swelling while
Yeah, but
performing.
once it is
while
completely
performing this
reducible,
test.
once
Sir.
it is completely reducible, you
Sir.
are able to get above the swelling, correct?
Yes, sir. We can get above the
So
swelling.
when you present your case, it has to be properly done, according to me. You will get caught unnecessarily with arguments with the examiners. So you have to tell that after reduction, I could get above the swelling. My suggestion to you in examination. Okay, good. Presentation is excellent.
If you are seeing,
Getting
Maria,
above
if
the
you are
swelling.
seeing,
Okay, getting above
Maria,
the
if you are
swelling.
seeing,
Yes, sir.
yes, sir, you can speak. Ajay, sir, you can speak.
No, I was just telling her that getting above the swelling comes in a very initial part of palpation. Okay, it doesn't come so down.
Oh,
So once
okay,
you
sir.
have seen that it is a non-tender and local temperature not raised, then the next step comes is the whether you are able to get above the
Get
swelling.
above the swelling or no? Okay, sir.
So you do not reduce and then tell about that.
See, what is the idea behind doing getting above the swelling? Why do you do that test?
Yeah,
Sir,
Maria,
sir.
my opinion is if you are seeing there is a inguinal swelling is there in a inguinal part, then it does not make any sense to check for the get above the swelling. Swelling is already there in the inguinal region. So why are you checking for get above the swelling?
Okay, sir.
Actually,
Sir, to
see,
rule out
getting
whether
above
it
the
is
swelling is basically
pure.
done to differentiate between pure scrotal and
Yes, sir.
inguinal
Pure
scrotal
scrotal or
swellings. That is the right.
inguinal.
So
Yes, sir.
Ajay sir was very right. Being in inguinal scrotal swelling, you always have a doubt, especially not talking about only this patient. If suppose it's got a flabby inguinal fat pad, then it may not be, you may not be able to appreciate the inguinal part of that swelling, and only it may be appearing in the scrotum. So that in those cases, it may become important to do. That is the whole idea.
Yes,
You can definitely,
And
you can.
one more observation, you have mentioned something about 6 centimeter below the SIS. Impression is giving that you are talking something in the thigh or something. So it is medial. You can start from mid-inguinal point or medial to ASIS or inframedial. That will be probably a better description than below ASIS.
Okay.
That is my take on that.
Maria,
Okay.
how did you do it getting above the swelling? How did you do it? How did you do the examination?
Sir, patient wasn't standing. Ask the patient to stand up, sir.
Then how did you do reducibility?
Sir, I asked the patient to lie down, sir.
So both are palpatory findings, am I right?
Both are palpatory findings, yes.
Exactly. While presenting, before you make him lie down, patient is standing, you are sitting down with the eyes at that level, doing this test first. That should have been written first, what Kanna sir was mentioning. Then you made the patient to lie down, then did the reducibility.
Oh, so first getting above the swelling and
Exactly,
then
exactly. Patient is standing initially. You are sitting in front of the patient with the eye views at the level of the scrotum, holding both the hands like these. In fact, you should be doing both the sides.
Okay, sorry.
There are 2 points you should mention when you do this test, like undergraduates. 2 things. One is getting above, second is thickened cord, because you are comparing with the opposite side.
Yes.
Again, the questions you will be inviting once you say cord is thickened on the affected side. What are the reasons for thickened cord in a inguinal hernia?
Okay.
You got the point.
Yes.
So what are the reasons for the thickened cord on the affected side? One is obviously sac is there.
Tuberculosis, sir.
Arey, lady, I'm not asking what's difference thickening. I'm asking about an inguinal hernia cord. I'm not asking nodal or what's difference. I'm asking in a case of inguinal scrotum swelling, you said getting above the swelling is not possible in a standing position and the cord is thickened.
Okay, sir.
Compared to opposite side, you should do simultaneously like this.
Sir.
So one thickening for cause for the thickening of the cord is presence of sac with its contents, obviously, because it's a case of hernia. Second
Yes.
reason, any other reason why cord will be thick than the normal side? Anything gets hypertrophied there in case of inguinal hernias, which we demonstrate while doing surgery?
Congenital hydrocele.
Right, hypertrophied, which we cut and demonstrate during surgery, inguinal hernia surgery, open inguinal hernia surgery.
The sac.
Cremaster muscle, cremaster muscle.
Cremaster muscle.
Hypertrophied cremastic muscle. Okay. So you should present in the same order. That's why I said you have read well the slides, you have read well. Like what sir said, no, Dadvi sir. You have read the slides well without putting in order. So in the same manner you should present. Standing, above the swelling, made him lie down, reducibility present. Then deep ring occlusion test. They should come in the same sequence.
Okay, what are the fallacies of ring occlusion test? When it may fail?
Sir, it will fail in case of direct hernia.
No, that is, you are doing it to differentiate between direct and indirect. When it may not give the true result.
So sometimes the ring will be wide, sir.
Sometimes, why sometimes? If the ring is wide, it will probably fail. Just imagine you are occluding with the thumb, ideally is thumb, but just imagine the ring is wide enough.
Yes.
So still the swelling will appear despite your occluding. And any other?
Pantaloon hernia.
Yes, when you are having both the sacs, then also result may not be true.
Any other fallacies? If you may not able to locate properly deep inguinal ring. If there is no proper location, that may also be a fallacy.
Oh, okay, sir. Improper occlusion, improper location.
Improper location.
Yes, sir.
Will it help in classifying the hernias other than direct and indirect according to EHS by examining the deep ring? Will it help us? You know what is EHS classification?
Yes, sir.
So will it help by after reduction? Can you find out something there at the deep inguinal ring?
Yes, sir.
What? So that you can grade the hernias, you can, according to EHS classification. Whether it admits single finger, two fingers, so that you can approximately measure 1 centimeter, 2 centimeter, more than 2 centimeter defect of the deep inguinal ring.
Deep
Yeah.
Yes.
And I don't know about other examiners. G-man test, at least in my institute, I discourage people doing that, and hardly it matters anything. Like G-man's test, not to be mentioned and not to be done. I don't know Vipul and Garak sir, but
I agree, sir.
it should not.
I agree, sir. Yeah.
G-man test. Don't mention. Okay,
Yeah.
fine. Okay, fine. Your diagnosis and treatment, lady. Yeah.
The diagnosis is right-sided, uncomplicated, acquired, reducible, indirect, complete inguinal enterocele. with bowel as its contents.
I'm seeing some new word here, acquired. I don't know. You wanted to make a bigger diagnosis?
Yeah. And if it is written enterosil, it doesn't make any sense to write bowel.
Yes.
Okay, so probably she wanted to make it as a two-line diagnosis. Okay, anyway. So what is that you want to do? Acquired, why acquired for a aged fellow is 70 plus?
And if it is enterosil, bowel is not required.
Exactly, exactly. Make it simple,
Okay.
no? Make it simple.
Yes.
Yeah, it's
Yes.
yeah, fine. And when you examined it was enterosil. When I examined, probably it would have been vomentosil.
Mm. Yes.
Then you have to write that also during my examination. Like that also you should give the diagnosis. Okay. Dalvi sir wants to speak, sir.
No, I just want to tell her, Maria, just keep on telling us right-sided understood, uncomplicated because it is reducible understood, acquired Y, reducible understood, indirect understood, complete understood, and the other questions which have been asked by Dr. Vipul. Why acquired?
Sir, because the patient gave a history for a short time. He did not give it since birth.
See, this patient has a hernia since so many years. He has come to you because of pain 1 week ago. Correct or no?
Sir.
So, pardon?
Yes, sir.
So why not congenital? He ignored it.
Because it was not there since birth, sir.
No, not birth. The processus vaginalis was open. He didn't bother about it. He's driver. So he's sitting.
Yes, sir.
I'm just trying to tell you, when you put words in examiner's mouth, acquired, there has to be a cause. Do you have a cause in mind?
Occupational.
Occupation, driver. Does driver have hernia?
Yes, sir.
How?
Sir. Because of clutch, sir.
Clutch? Which side hernia the patient has? Right-sided.
Right-sided, yes, sir.
So how? Who presses clutch in India?
Left
and
side.
on which side?
Left side.
Then.
Sorry, sir.
Sir, sir, the next the question is.
Wait.
Self-starting
I want to
vehicle.
just teach her how to present a case. Reducible is okay. Indirect, absolutely agreed. As somebody suggested, enterosil with bowel, enterosil is bowel. And it is reaching the scrotum.
Yes.
Correct, Maria?
Yes, sir.
So it's a complete hernia that you're trying to tell us.
Yes, sir.
Now, why acquired? It might have been present years back, but patient never came to you because he had no problems.
Oh, okay.
So whenever you present such a case in an examination, practical, this is different. Examination, you got to be very choosy with the words that you use. Okay.
Yes, sir.
Yeah, because it can go this way or that way. Now the examiners can care. I'm just trying to help her. That's all.
Maria, when you say uncomplicated, okay.
Yes. Yes, sir.
Automatically it takes away the reducibility, jo hai na?
Oh, okay, sir.
Okay. So that is a duplication. Okay.
Don't
Once
try to make
uncomplicated,
unnecessarily
it has to be
complicated.
reducible and the cuff impulse has to be present.
Okay. Sorry,
Right.
sir. Yes,
Then
sir.
enterosil with bowel as its concern, enterosil itself means the bowel jo hai.
Yes. Sorry,
Right.
sir.
That is also not correct. And I'm not sure it is complete or not. Because from your picture, it looks like a funicular variety. Because you are able to feel the testis separately. And
yes, sir.
we could see the lower end of the sac going only up to the upper part of the testis only. So probably it is not a complete one. You know what are the various types of hernias according to the extent?
Yes, sir.
Mhm.
First is bubonocyl, sir.
Yes. Bubonocyl up to what place?
It is only till the ring, sir, but it does not extend
Which ring?
deep ring, sir.
No, no.
Sup
Deep ring it is coming from the deep ring, isn't it? But up
no,
to what extent it is?
superficial ring.
Yeah, it's a superficial ring, you know.
Yes, sir.
Okay, then second variety is?
Second variety is funicular, sir.
Okay, what
It
is
is
that?
it is reaching the scrotum.
Up to what place?
It is reaching the scrotum, but only till the upper pole of epididymis. It's not
Upper
going
pole of testes, you know.
upper pole of
Upper
testis.
pole
Yes.
of testes. Okay.
Yes.
So that is funicular variety. And
Funicular
deep variety is when it goes to the lower part of the testes here.
lower part
In
of
that
the
case, the testes will not be palpable separately here.
separately. Yes.
Okay. So these are
In
the changes in your diagnosis. And then you can also talk about the EHS here. Okay.
In bubonocyl, better you mention limited up to the inguinal canal.
Up to the inguinal canal. Yes, sir.
Yeah, that is bubonocyl.
Okay, sir.
And then you can tell about the EHS classification. What is the EHS in your case?
Okay. I don't know.
P and R. P and R. It is primary or it is recurrent. So in your case, it is the primary hernia. No?
Yes, sir.
And then second, you have to tell about how much is the width of the deep ring is there. Whether it is less than 1.5 centimeter or 1.5 to 3 centimeters or more than 3 centimeters.
NIHS classifications.
No, I'm talking the EHS classification. That is the most accepted classification nowadays. There are so many classifications are there, but I am telling you about the EHS classification. And third is whether it is L or M or it is F. What is LMF?
Lateral, medial, or femoral.
So where does your patient fits? In which?
Medials.
It is medial?
Yes, sir. Medial to pubic tubercle, sir.
No, it is not medial to tubercle. Indirect variety is lateral one, L.
Okay.
Direct variety is M.
M. Okay, sir.
Femoral variety is F.
Okay, sir.
Okay, so to tell about the EHS classification, when you're giving so much big diagnosis, it's important. So you will say here, it is P1. 1 means less than 1.5 centimeter, and it is L.
1.5
P1L. Okay. Primary, less than 1.5 centimeter defect in the deep ring is there, and it is the indirect variety or the L variety.
It is indirect variety. L variety. Yes.
Yeah. Okay. Go ahead. Yeah.
Okay, Maria, why do you need these classifications? There are various classification, EHS, NIAS, Gilbert's, and so on. What is the importance? I say, how does that matter?
For the management modalities, sir.
How will it differ?
No.
So one argument is if your surgical choice of the procedure changes according to the classification, then it is okay. Okay. But sometimes it may, depending upon the expertise of the surgeons and the local factors of the hernia. So we should understand that. Okay. Now see, if you are doing a laparoscopic surgery, anyway, mesh size is same for all types of hernia. If you are
Yes,
doing an open anterior approach, again, you're going to put in the same size. So we should understand that classifications, okay, good. And they are for academic discussion. Sometimes they may do help in deciding the choice of the procedure and maybe explaining somewhat prognosis in today's medical legal, that also we should understand.
Okay, sir.
Does
Okay.
When you
it
have the
make any
P and
difference?
R, you know, when you say it's a primary hernia or it's a recurrent hernia, definitely it makes a difference. Hai?
Yes, sir.
And Dr. Nitin is right in saying that as far as the posterior wall repair which is there, it is almost the same size of the mesh, whether you are giving in the open, it is different sizes there, in the laparoscopy is the different sizes there.
Yes,
But
sir.
it doesn't change the according to the how much the defect is there. But it
Yes.
also matters whether it is L or M. Because it is a L variety is there. In that case, majority of the time you are going to excise the sac.
Yes,
While
sir.
in the case of the M variety, you are not going to excise the sac, but you're just going to push that and plicate that. So that is the difference, that why you want to know about these things, that what type of the EHS classification it is. Okay.
Yes, sir.
Does it make any difference whether it differentiate between indirect and direct hernia in today's era? Does it help in differentiating between direct and indirect hernia?
Yes, sir. It helps.
How?
Sir, for procedure, sir, we have to manage direct hernia, delivering sac, sir.
That is on table, you can differentiate. Now, clinically, is there any relevance in differentiating between direct and indirect hernia?
Sir. Clinical difference, sir. Pardon me, sir.
Yeah. Is there any relevance in differentiating between direct and indirect hernia clinically?
Yes, sir. Direct will be medial to inferior epigastric artery, sir.
No. I don't want to say that. Whether it make any difference if you differentiate clinically that patient is having indirect hernia or patient is having direct hernia. Will it make any difference? Or say, suppose I say management point of view, will it make any difference?
Yes, sir.
Pre-operative. I am saying pre-operative. Ultimate management, you are going to put a mesh.
Yes, sir.
Yeah. So how it affects the management?
Sir, herniatomy. Herniatomy is done in indirect, sir.
In a 40-year-old male with indirect hernia, anyway, let it be even a small, would you be satisfied with only doing a herniatomy procedure?
Yes, no, sir.
See, sir is asking probably in pre-operative or a clinical examination, anyway, you are going to do 2 or 3 procedures, whatever, laparoscopic or open. What is the use of differentiating or benefit of differentiating between direct and indirect hernia? What should be your answer as a postgraduate candidate?
Sir, in direct hernia, it is the etiology is due to.
Okay, I think probably she's not getting the.
Yeah.
I think we should have a very clear answer to these people. The students must know about that. You must know whether it is the indirect hernia or a direct hernia, even pre-operative also. The reasons for that is that you go with that intention that are you going to deal with a indirect hernia or a direct hernia, because direct hernia are much easier to tackle as compared to the indirect hernias. In the case of indirect hernia, you have to dissect it from the sac, while in case of direct hernia, you have to just push it back. There is more chance of having the testicular vessels injury in the case of the indirect hernia as compared to the direct hernias. In the case of direct hernia, you have to, apart from reduction, you are not going to excise the sac there, but you are just going to push it inside and may plicate that area.
Yes, sir.
In the
Yes, sir.
case of the indirect hernia, you are majority of the time going to excise that sac. In both cases, you are going to push the mesh. There's no doubt about that. But these are the
Yes, sir.
various differences that you should know even beforehand, that whether you are going to deal with the case of direct hernia or indirect hernia. That is my contention.
Theoretically speaking, indirect hernia are more prone for complication as compared to direct hernia in the
Yes, sir.
form of obstruction or in the form of strangulation. Direct hernia are less likely to go for obstruction or strangulation. That is theoretical possibility. So as a postgraduate, you can give answer like that, but in a practical scenario, we haven't seen like that. So practically speaking, even latest edition of Sabiston also mentioned that it doesn't make any difference pre-operatively in differentiating indirect and direct hernia, because management is going to be the same. Ultimately, you are going to put a mesh. So it does not make any difference, right? But as a
Yes.
postgraduate, you must mention that direct hernia are more likely to complicate indirect hernia. As compared to direct hernia,
No, direct
indirect
hernia less
hernia, you have to
complicated.
excise the sac, transfix the sacs. So the management is difficult as compared to direct hernia, in which direct hernia is just have to replace the sac and put the mesh. So management is easier in direct hernia.
So
Yes.
indirect
Maria,
has more complications than direct. That is what you wanted to say.
Yeah.
Thank you.
Maria,
Yes, sir.
you must have assisted or done surgery, no?
Yes, sir.
Fine. Why all of us are highlighting that in a direct hernia, we are not opening, pushing it back and placating? Why is that we don't want to open the sac in the direct inguinal hernia?
Sir, unless and
And why
until
we
there is,
don't try? Why we don't try excising sac? Why we don't try opening the sac in a direct hernia? What is the reason?
sir, in direct hernia, the neck will be wide, sir, and only in case of obstruction we have to open the sac, sir.
All of us said just
Maria?
now that complications are more in indirect hernias, and I am asking about direct hernia where we don't expect complications, so you'll be able to reduce it. Why is that we are reluctant to open a direct hernia sac? Why we are reluctant that we don't excise the direct hernia sac?
Guru Shantapa, let me ask her a question.
Sir, probably she will not be able to answer our questions.
No, she
and
will
probably
be able to answer. Maria,
okay, sir, fine.
what
Yes.
is the anatomy of the defect in direct hernia and indirect hernia? He's trying to ask you why indirect hernias are likely to get more complicated as compared to direct hernia. I am sure Guru Shantapa will agree with me for this question.
Sir, indirect hernia will have a narrow neck, sir, whereas the direct hernia will have a wide neck. And direct hernia will come from the Hasselback's triangle, sir.
See, do not talk about Hasselbalch triangle, etc. Now, questions will be asked to you about Hasselbalch triangle. And then who was Hasselbalch? Guru Shantapa, please take over. I think her answer is satisfactory.
You know, it is good to know that indirect hernias are more likely to get complicated as compared to the indirect hernia. But if you start operating a direct hernia and you start opening the sac there, you are more likely to damage the thick extraperitoneal fat which is there. The bladder may be there, the bowel may be there, and you are going to damage those structures there. And that is why you do not open the direct sac. You just push it inside you, no?
Yes, sir.
Yeah.
In fact, more so on the left side where it could be a sliding hernia.
Yes, it will. Yeah.
Yes.
When do you expect a sliding hernia or component to be present? So on clinical examination, or you are just, when will you expect a sliding? Though it is very difficult, I will put in a caveat, it is very difficult to diagnose sliding hernia clinically. When should you expect? You are a young surgeon. ends up, it pops out. So when should you expect?
In case of big hernia, sir, it is
Yes.
coming into the scrotum.
So one is especially direct large hernias and
Large
long
hernia.
swelling. Should
Yes.
expect a sliding. Why is it important to know?
Sir, again, because of the content, bladder.
No, see, content. Why as a surgeon it is important to know there could be a sliding component. Until you have at the back of your mind what damage you may do. So you may injure
Maria,
that organ which is sliding, okay?
Sir, Nitin
So you
sir,
should always
before she-
expect. So that is the importance of knowing that there could be a sliding component.
Back to the
Yeah.
in Maria, in sliding hernia, is the bladder is a content or something different?
The wall of that.
Is
content
it a content? Will it be a content?
valves forms the wall, sir.
Will it be a
Medial
exactly
wall.
exactly? All of us are what we are highlighting in these situations. Why we don't open is it can be a part of the wall of the sac. If you try opening the contents, probably we may open the wall itself.
Oh, okay, sir.
You understood? So don't mention for a direct hernia as a content. They will be
Okay, sir.
part of the wall.
Okay, sir.
How
Okay,
will you
coming
treat this patient?
will you require any confirmatory test?
No, sir, because hernia is a pure clinical diagnosis.
Okay, when do you require the help of the investigation in a case of groin hernia? When you may require.
In case of occult hernia, sir.
Yeah.
Over the opposite.
Occult hernia, but there will be some presentation, no?
Can you define occult hernia? Can you define?
Sir, there is no obvious clinical signs of hernia, sir.
But clinical symptom, huh? Otherwise, it won't be a patient. Why would the patient? So patient is having some groin pain or complaint, and clinically, so in essence, a very small or when the hernia is starting, that time you may require an ultrasound. Any other indication
Ultrasound.
of doing an ultrasound?
To check the vascularity, sir.
Why? Oh, that is okay. Complicated, uncomplicated hernia. Any other clinical scenario where you may require the help of ultrasound? Very obese patients, small hernias. Again, it may be difficult to diagnose in very obese patient. I'm talking about morbidly obese, maybe 100 kg. So clinically, sometimes you may miss out on the diagnosis.
To know the size of the ring, sir. In that case.
No. To diagnose whether it is hernia or not. Sometimes it may be difficult in morbidly obese patients to diagnose a case of groin hernia. Inguinal hernia, I should say.
Yes, sir.
What is sports hernia?
Sir, it is pain in the groin region, sir. But there is no obvious signs of hernia, sir.
So here hernia is a misnomer. Basically, chronic groin pain, especially occurring in athletes. So how will you make whether how will you be sure whether am I dealing with sports hernia or a true hernia?
USG.
How will you be sure whether you are dealing with a true hernia or is it a case of sports hernia?
Sir, no clinical signs of hernia will be there, sir.
Again, you have to do an investigation, maybe MRI or a high frequency ultrasound. Okay.
USG.
At least aware of the term sports hernia. Hernia is a misnomer.
Misnomer, yes, sir.
What will you do for this patient now?
Sir?
What will you do for this patient now? Will you send him back? What is the plan
No,
of management?
no, sir. First, I will get all the surgical profile done, sir.
Okay, he's physically fit, declared fit. He's got
Yes, sir.
morbid.
And he is a 40-year-old male, so I would like to go in for mesh repair, sir.
You told something about herniaotomy. You remember?
Yes, sir. But herniaotomy will be more commonly done in infants. Hernioplasty.
That means
I
10
mean,
or 12 years of age.
in pediatrics, most commonly, yes.
What's your plan
Is
of?
there any demarcation of age for herniaotomy and herniorrhaphy or hernioplasty? Up to what age you can perform herniaotomy?
Sir. Oh, pediatric will go in for herniaotomy, sir. Most of the cases.
What do you mean by
Up
this?
to what age? Up to
Middle
what
age.
age?
Up to 8, up to 12 years. 10 to 12 years, sir.
Up to 18 it can be done.
Okay, sir.
What's your choice of surgery for this patient now?
I would like to go in for hernioplasty, sir.
Which hernioplasty?
Sir, most commonly done hernioplasty is Lichtenstein's hernioplasty, sir.
Okay.
Tension-free repair.
Why do you call it tension-free?
Because after suturing, it will not cause any tension over the ligaments and
means
after fixing, sir. After fixing.
Can you describe a full name depending on your diagnosis? Describe a full name of that operation depending on your diagnosis, the operation you perform.
Lichtenstein, sir. Lichtenstein tension-free mesh repair, sir.
Suppose you are a resident in your unit, diagnosis is mentioned on your screen. So in your discharge guide, what you will write as an operation?
Hernioplasty, sir. Hernioplasty, sir.
Right-sided. You should start with a right-sided Lichtenstein tension-free hernioplasty. That is the full name, right? So in examination also you should describe like that.
Okay,
because
sir.
your case is like that.
Okay, sir. Yes, sir.
Do you know any other hernioplasty?
Yes, sir.
Just name. Can you name?
Gilbert's plug, sir.
It means what are various ways of
Proline
open
Proline
hernia
hernia
repair?
system.
Basic two approaches are there. What is anterior repair? What is posterior repair?
Anterior repair will be inguinal approach will be there, sir. And in posterior through the posterior wall.
Posterior?
Bessini procedure is the
Bessini is posterior repair.
No, anterior approach. Anterior approach.
So anything you are doing means anterior to the posterior wall, that is anterior approach. And if you're approaching the sac behind the posterior wall, that is essentially in the preperitoneal space, that is posterior approach. So recommended is anterior approach. Any specific situation where you may resort to this posterior repair? We are talking only about open hernia surgery now. In this patient, I have to go for posterior approach. Recurrent hernias. If patient is having a recurrent hernia and your only option is open surgery and previously he has been operated by anterior approach, then you have to go through a posterior approach. Okay.
Posterior approach. Yes, sir.
Okay.
Okay.
Maria, have you heard of Reeves Stopa?
Stopa repair. Yes, sir.
What is it? If you know, you tell. I think the examiner is trying to
yes.
ask you that question.
It pantaloons are. Oh, pantaloon.
Where is the mesh placed in Reeves Stopa repair? That is what he's trying to ask.
Between the peritoneum and the fascia transversalis.
Garg sir, you can continue.
The mesh is placed between the pre-peritoneal mesh repairs.
So, Garg sir, you can continue, please.
Maria, do you know any condition where you do a herniotomy, but it is not a case of hernia?
Congenital hydrocele, sir.
Good. Yeah. In congenital hydrocele, you do that. Yeah. Now, what are the various laparoscopic techniques for the inguinal hernia repair?
Sir, broadly there are two, sir. Trans-abdominal peritoneal repair, sir, and extra peritoneal repair, sir.
It's called a TEP.
TEP.
What is TEP?
Extra peritoneal, sir. In that,
What is TEP? What does the T stands for?
Total, sir. Total.
Total extraperitoneal.
Totally, yes, sir.
And what is ETEF? ETEP?
ETEP. Extended.
Extended or enhanced? No?
Extended or enhanced.
Enhanced.
Yes, sir.
Total extraperitoneal approach. Okay.
Yes, sir.
So if the patient has got a bilateral inguinal hernia,
yes, sir.
which one you will prefer, the TEP or TAPP?
TEP, sir. TEP.
What is the advantage of doing the TAPP over TEP?
Sir, TAPP, we are going into the abdominal cavity, sir.
So what is the advantage?
Trans-abdominal approach, sir.
So any advantage over the TEP? Which one is better? TEP better or TAPP better?
Sir, TEPP is better, sir.
TEP is better, no?
Yes, sir. Extra peritoneal is better.
Better than the TAP.
Better
So,
than the.
where you do a TAPP?
In cases of failed TEPP, sir, and
technically TAPP is better than the it is easier than the TEP.
It easier,
Okay,
sir.
it is easier,
But,
and if you have to do some associated pathology, like somebody also has got
yes,
the gallstone is there, or the umbilical hernia
yes,
is
sir.
there. Okay,
Prostatectomy also. Yes, sir.
you can do otherwise the TEP technically it is difficult, but it is better.
It is difficult and better, sir. Yes, sir.
Maria, do you know any open hernioplasty technique in which in indirect hernia sac is not opened or not cut but reduced?
No, sir.
Patient is having indirect hernia,
Yes, sir.
but sac is not open and sac is reduced.
Not open and no, sir. I don't know, sir. Sorry.
You go and read, there is a landmark paper in 1993 published in Journal of American College of Surgeon. That senior author was Lichtenstein, and along with amide, they published amide modification of Lichtenstein hernioplasty. So Lichtenstein used to cut the sac and transfix the sac, but amide used to reduce the sac, and they find very good result in that case. So they have to reduce the sac even in indirect hernia. So without compromising the result, without compromising the recurrence rate, they have very good results. So that is known as amide modifications of Lichtenstein hernioplasty. So many a time we perform that technique and we find also good results in that case.
Okay, sir.
Dr. Dalvi there.
Yeah, Maitra, there is a very good publication which has come from India, which does not use mesh. Can you name the person and the city from which this thing has come and is practiced in a lot of cities in US?
Desarda, sir.
Very nice. Do you know about the Desarda's repair?
Yes,
Have
sir.
you read about the Desarda repair?
Yes, sir.
Very good. Tell me what is done in Desarda repair?
Sir,
If you don't know, quickly say don't know. You're doing very well. That's why I'm asking you these questions.
external oblique is split, sir,
Correct.
and
And reinforced as a
reinforced
replacement for mesh.
replacement
That
for
is what
mesh.
it does. And
Yes.
it has been accepted. Can you tell me, have you seen or operated an inguinal hernia?
Yes, sir.
Very good. What mesh did you use?
Sir, polypropylene mesh, sir,
Right.
non-absorbent.
Very nice. Very nice. What is the color of that mesh?
White, sir.
Very good. What is color of proline suture?
Blue, sir. Dark
Blue.
blue.
Why the difference?
For why the difference? For better visualization? No, sir.
Better visualization where? In inguinal hernia or in using proline?
Using
Because for
proline.
fixation of the mesh, you are going to use proline or PDS, which are blue.
Yes, sir. Both are blues. No,
So
only
why
proline.
colorless mesh and why colored blue sutures? I'm asking you this question because you are doing very well, according to me.
Sir, better visibility, sir.
Of what?
Of
Mesh
the
or the suture?
both, sir.
Why not have proline in the same suture material, color? No, you have got silent. I'm not hearing you.
No, sir. I have no clue.
It's okay. No problem. I'll tell you. Dyed proline was used basically for cardiovascular surgery because red color against blood and blue were contradictory to each other and could be well visualized. That's why polypropylene sutures are always blue, as well as mesh does not want any dye to be used to put it in this. Okay, that's just a thing. I just wanted to ask you that tricky question because you're answering quite well. My second question to you is, in this new concept of, I think Dr. Khanna asked you this question about ETEP.
Yes, sir.
Have you read about ETEP?
Yes.
No, yes, no, yes, no, no. Say no, otherwise I will not ask you question.
No, sir.
No, no, it's okay. Anybody, any examiner can take. I am happy with her.
Thank you, sir.
Okay, Maria, 3 important nerves in hernia surgery.
Sir, ilio-inguinal nerve, ilio-hypogastric nerve,
Huh.
and genital branch of
Okay.
genitofemoral.
Now comes so ilio-inguinal nerve, when you are likely to injure? You are doing hernia.
During
Which step?
during the separation of
You can injure it anytime, most likely.
sac dissection, sir.
No, while cutting the external oblique muscle.
Yes, sir, while cutting the
Huh?
muscle.
Because it lies where you cut, it comes right there. Iliohypogastric?
Iliohypogastric, during sac dissection.
No, raising the superior flap, mostly.
Okay.
Genital branch?
Genital branch is with while separating the cord.
By lifting the cord. Huh?
Lifting the cord,
Lifting the
separating the cord, yes.
cord. Because it lies posterior and external to the spermatic cord. Very unlikely to endanger while separating the cord, but very likely to be endangered when lifting the cord and maybe pulling it away from your surgical field.
Operating field, yes, sir. Yes.
So suppose you are having a very large sac like this patient. So how will you deal with the sac after dissecting it? It's a large sac going into the scrotum, mid-scrotum almost. You have lifted the cord, dissected the sac. Now what will you do?
Sir, after reducing the content, sir, I'll transfix, excise, sir.
Where? So do you aim to excise the whole sac?
No, sir, not the whole sac, sir.
Then
Only
that is what I'm asking. How will you approach the sac now? You have separated the sac from the cord structures.
Yes,
sac
sir.
is lying on one side, cord structures are separate and safe in a way. So how will you deal with the sac now?
Excise from the preperitoneum.
Sac is going into the scrotum. So how will you deal with the sac? You are the chief operating surgeon.
Will
you dissect the whole sac?
No, sir. I'll not excise the
You
whole.
pull out the sac from the scrotum in total, or will you keep the sac in the scrotum itself?
So
or will cut in between?
What is the distal landmark for dissection? Never beyond the pubic tubercle. That is the dictum. Okay. Never beyond the pubic tubercle.
Yes,
if your sac ends there a bit, it's okay. So you have to transact it in the mid-inguinal canal and then do a transition or whatever you want, way you want. Okay.
Yes.
So idea is you not dissect the it may lead to hemorrhage, injury to your pampiniform plexus, hematoma formation.
Yes, sir. Yes. Scrotal vessels will be severed, sir.
Not scrotal vessels, testicular.
Pampiniform plexus, yes.
And you should take care that you do not close the distal sac.
Yes, sir.
Okay. Because if you close the distal sac, what will happen?
There will be entrapment of the cord, hydrocele, sir. Post.
Yeah, there will be post-op hydrocele.
Post-op hydrocele will be there.
We should not close that, yeah.
Yes, sir.
Maria, how will you fix the mess?
Sir, first we have to make space for placing the mesh, sir, dissection. And first suture is taken, anchoring suture over the pubic tubercle, sir. From internal to From medial to lateral side, we should suture it, sir.
So your medial end would be at the pubic
Yes.
tubercle?
Or it is beyond the pubic tubercle.
No, sir. Anchoring suture should be taken on pubic tubercle, sir. Pubic
End
bone.
of the mesh, end of the mesh should beyond the pubic tubercle, or it should
on the pubic tubercle.
on the pubic tubercle.
Should be always beyond the pubic tubercle. Right?
Always it
least
should
2
be 2 centimeter beyond the pubic tubercle.
Okay,
It
sir.
should not be at the, because ultimately mesh is going to
Contrast.
shrink by 25%.
Yes, sir.
So the most common site of recurrence is the pubic tubercle. So if you fix at the pubic tubercle, the patient is going to recur. So that point should be taken care, and mesh should be fixed 2 centimeter beyond the pubic tubercle. And the suture should first stitch should be taken at the pubic tubercle. There is no doubt. So that is one point. Second,
Second, along the length of the mesh, we have to suture, sir.
so how after pubic tubercle, how will you proceed?
With inguinal ligament and conjoint tendon, sir.
Which suture material will you use?
Sir, Proline 20, sir.
Proline 20.
Yes, sir.
Throughout.
Sir?
Throughout Proline 20.
Yes, sir. Throughout Proline 20.
On the conjoint tendon also. On the upturned part of the inguinal ligament also you will use Proline 20.
Vicryl also can be used, sir. 10.
I'll agree Proline 20. I'll agree Proline 20 on the upturned part of inguinal ligament and pubic tubercle, but little differ on the conjoint tendon. We prefer non-absorbable suture on conjoint tendon. Can you tell the reason? It can be a vicryl or can be a PDS, and that to be not tight suture, it should be a loose suture.
Approximation, at least.
Yeah, just approximating suture using non-absorbable either vicryl or PDS. Why?
To tension, to release the tension over the.
Anyway, you are going to put a mesh and the repair is going to be tension free.
Yes, sir.
So tension is not the issue by putting a suture. You can put a Proline also. In the past, when we were a resident, we used to Proline. But as the advances in the science has developed, now we are using non-absorbable suture, either vicryl or PDS.
Yes, sir.
Absorbable suture.
The reason is, if suppose some nerves come in between, the suture is going to absorb within a 3 months. So the nerve will be released. So the pain will not be a longer. So the chronic inguinal hernia will not be a problem in that case, and loose suture will not entrapment of the nerve. So that is an advantage of using non-absorbable suture over the conjoint tendon. So you can use a two suture, right?
Okay.
No problem for that.
Okay.
And mesh should always use a expand mesh, not shorter mesh. Use a longer mesh. 10 by 15 mesh is advisable.
Yes, sir.
Yeah. Abhay Dalvi, sir, would you like to add anything?
I just take her away from operative discussions.
Yeah.
Do you know what is sports hernia?
Yes, sir. It is a misnomer, sir. It is a chronic groin pain.
Due to what other causes then after inguinal hernia repairs that you can diagnose that this is sports hernia? If you don't know, say don't know quickly because you have done well. So I'm asking you these difficult questions. उधर इधर देखना नहीं, डायरेक्ट देखना कैमरा की तरफ.
No, sir. Don't know.
Name one actor film actor in Hindi cinema who has undergone an inguinal hernia repair? Who went into Bridge Candy Hospital at night, got operated, and walked out in the morning? No, I'm just asking you these foolish questions, as I would say.
Amitabh Bachchan.
Huh?
No,
Amitabh
sir.
Bachchan underwent surgery for incisional hernia at Lilavati Hospital. I'm talking about Bridge Candy Hospital. A muscular man.
Muscular man.
I'm on my
No idea, sir.
Salman Khan.
Okay.
Remember it. Okay. Chal.
Okay.
Bye. Good night and
Thank
do
you,
well
sir.
in life.
Thank you so much.
I think we can Kannavel sir? Kanakvel sir? Khanna sir, can you connect?
Dr. Rahima, do you have any questions for the faculty, ma? Do you have any doubts to be clarified?
No, sir.
Kanna sir, other faculty, any comments, sir? Can we call the session a close, sir?
I think, yeah, we can close it here.
I'll just come in here. For her, she has to read a little bit of history. What is Bassini's repair? What is Shoulder's repair?
Yes,
What
sir.
is,
McVeigh's
repair? All
Yes.
these things you got to know because these questions may come up, especially from senior examiners like me, because we have dealt with open surgery much more than laparoscopic surgery.
Yes, sir.
Laparoscopic surgery easy to answer, but read a little bit of 3 stages of hernia repairs, which is available in Mango, and you will be able to answer all the questions from senior examiners. Thank you.
Dr.
Okay.
Dalvi,
Dalvi,
how do
Dalvi, sir.
you pronounce
Khanna
Liechtenstein
sir.
repair?
Khanna sir.
Yeah, I'm just asking you, sir.
Yes, sir.
When we say the Liechtenstein repair, which is there, some say the Liechtenstein repair is there, some say Liechtenstein repair is there. What do you say, sir?
Sir, it is to me to remember the spelling correctly. It is Liechtenstein's repair for me to pronounce and fill it correctly. So
Like
LICH.
I always say Liechtenstein repair.
No, whatever it is
Yeah.
pronunciation different
Yeah.
countries, but
Yeah.
to remember the spelling becomes very important. So 84 he described it as I remember. Shouldice in 1882, E.E. Shouldice from Canada, Toronto. So these are the things which are there.
Mhm.
These people should not be knowing it, but at least what is the principle of repair? Like Liechtenstein described polypropylene continuous sutures. We always take interrupted sutures. The principle behind a tension-free repair has always been that you have a floppy mesh which moves with respiration and not a very tight repair. So these are some principles which have to be actually conveyed to all these students, which should be conveyed. I don't know.
Yeah, I think the Dr. Parvez Ahmed, which is there, he is the main person now carrying out all these things.
Huh.
And he has been to Gangaram Hospital and many other hospitals in India. And he does that you should go at least 2 centimeters beyond that. It should be continuous suturing on the inguinal ligament site. You have to put 2 sutures, one over the posterior part of the rectus sheath and second at the conjoint tendon. And third, he has to always make a deepening. Artificial deepening has to be made. That is probably one of the most important thing. And he's always using only the Prolene sutures only. 20 or 30 Prolene sutures here. Even today, he's using the same one. Yeah.
So this is the conventional treatment from Shouldice's clinic that
Not the Shouldice. It is the Liechtenstein repair, sir. It is the Parvez Ahmed. Parvez Ahmed repair. Yeah. Parvez Ahmed is the main person.
Yeah, sir. That is known as Amit modification. I think that's what I am telling. Amit's modification of Liechtenstein repair.
Yeah, but also there is a good paper which has been published that you should go beyond the pubic tubercle and then take a suture at the pubic tubercle. So there are a lot of papers with recurrences rates, etc., which is going on. hernia has become a world problem, according to me. I'm sure Dr. Khanna will agree. With so many hernia societies and this bombarding open versus laparoscopy,
Yeah.
it should not be at PG level, examiner level at all.
अभय दलवी सर,
हाँ बोला.
I want to confess, अगर आप एग्जामिनर है तो किसी को कोई प्रॉब्लम नहीं है.
मैंने हमेशा सबको पास किया.
हाँ, इसीलिए मैं
Because these
I
people,
was
I'll tell
I
you.
was yeah.
हाँ विपुल बोल.
In 2005, I was in a Jamnagar as a resident. You were examiner in 2004, and you tell to the resident, "Don't worry, I am here to pass you only." तो वो sentence मेरे को याद है.
See, you realize one thing, that these people work for 3 years dedicatedly, and
Yeah.
just a stop of the brain does not allow them to answer. And then to bombard them with questions, it's much simpler to ask them simple questions and you get the answers. One day I will meet you and tell you a lot of things.
Sure, sir. I would also like to meet you.
Thank you.
Yeah. Thank you, sir.
Munira, Maria, all the best to you.
Thank you. Thank you so much.
Thank you. Thank you.
Thank you, Maria. It's been a wonderful thing. Now, please take note of all the lacunar areas and go back to the library and read about. That is all it's required. Good luck.
Yes.
to you. And thank you all the examiners.
Thank you so
for
much, sir.
joining us today. We will meet next Friday with more depth. Thank you very much. I'm calling the session at close. Good night, everyone.